Hello, my name is Taisei Jiba. I'm a second year professional athletic training student at the University of South Carolina. Today, I will talk about a structural non-operative treatment program for traumatic triangular fibrocartilage complex tear acoustic experimental study. Triangular fibrocartilage complex (TFCC) is a group of ligaments and cartilage structure comprising an articular disc, meniscus, humerus, ulnar carpal ligament, extensor carpal ulnaris subspace, and the dorsal and the boral radial ulnar ligament. You can see the picture how it looks like TFCC. TFCC plays a key role in stabilizing ulnar carpal joint as well as a cushion and enables to the movements complex movement in the wrist. TFC is one of the common causes of the ulnar side wrist pain. TFCC injury it can happen traumatic or degenerative. The patient felt the wrist pain, creaking, or sensation during the movements, and also patients felt instability feeling. Range of motion is usually limited, especially in the forearm rotation and the limited ulnar deviation. Special tests you can use Holberstein ulnar carpal stretch test, passive forearm rotation test, and piano key test, and they are usually abutment test, which I can show the picture on the right side. Imaging will be MRI is conducted due to the confirm of diagnosis. You can see the picture on the top side of the MRI. Looks like somebody TFCC injury. Management determined by conservative or surgical depending on the structural injury. Usually TSCC inside is a vascular structure, so it has to be deal with surgical, but it can deal with conservative. However, a limited clinical trial on the effectiveness of the conservative management in patients with TFCC. So, this research is aims to evaluate the efficacy of the structural conservative treatment program for TFCC patients with no-growth DRUJ instability, and effectiveness of the five-stage rehabilitation program, which adds some aspects to the traditional program. Inclusion and exclusion criteria is as you can see here. Participants was number is 30 to 84% had regular sports activity and occupational strength. Most of the patients were less physical demanding job. Rehabilitation program. So divided phase 1 to phase 5. So after the phase 1 tissue healing phase, phase 2 the patient studied auto brace, so early out of immobilization and gentle range of motion was studied, and the phase 3 nocturnal surgical tongue brace was changing and the exercise was adding in addition to the range of motion, early proprioception exercise was adding in this phase. Phase 4, patients being from sugar tongue blades, and the exercise was also a more complex task of the proprioception as well as servant exercise. And phase 5, advanced proprioception training was added, and the patient was wrist brace taping for the sports. The exercise was more complex, advanced proprioception such as PNF or Powerball. This is exercise, but it looked like in the right side on the purple ball, it's a purple, and also you can use the servant or formula exercise how it looks like. Measurements. This outcome measurement was used and collected at the baseline, end of phase 2, and end of the program. Results outcome measurements. Pain scale was and the stability was significantly improved in the 6th phase, and also end of the program. You can see how pain scale was reduced in the compared with baseline, and also hand grip was improved. However, only 40% completed at the final data correction, so you have to be a little bit careful to the interpretation. Limitation patient demographic. The industrial setting population can be applicable, but will change to include athletic population. If you work athletic, you have to be careful to use this program. criteria are not much to the basic rehab progression and will differ in athletic population. Study design, participants' compliance, a lack of demographic information, lack of blindness control group. You can see only 40 patients was conducted at the final survey, and also there is no randomized control trial, so you cannot determine cause of effect in this research. Statistical analysis, lack of power analysis leads to difficulty with generalized results in normal patients, and significant analysis doesn't measure in different phase. Clinical bottom line. It is important to educate the patients about the importance of immobilization. Longer immobilization causes contracture and less good outcome. So it is important to educate the being immobilized, but also early out of the immobilized and starting range of motion exercise. And also utilize multiple outcome measurements to enable to see the how being able to measure the rehabilitation program. It is important to incorporate proprioception we have in the early phase and progress with criteria. Here's the difference, and thank you so much.